to the drive in the university is that it brings us together. Innovation and technology is not the sole domain of a few narrow areas of science. In fact, innovation and technology and creativity is driven to a large part by other areas. And so we have had an effort on our campus to try to bring together the arts and the humanities and business and the sciences and education, all of these areas together in order to think about how we can move innovation and creativity ahead across campus. And this is the inaugural event that will allow that to happen. So I'm going to shut up from there and turn it over to President Elliot Hirschman. President Hirschman has been here for less than a year. He has been a great example of innovation and creativity in higher education for a long period of time. But in addition, he has been very effective in innovation and creativity himself as a scholar. He has managed to bring together the areas of economics, mathematics, and psychology to study the psychopharmacology of cognition. And that's a great example of bringing things together to achieve innovation and creativity. So,
thank you very much, Dean Malloy. Good afternoon, everybody. I appreciate that you all were able to brave the rain to get out here. I know, being relatively new to San Diego, I know how challenging rain can be. I do want to welcome you to the College of Sciences Monty Award lecture by Dr. Bob Kaplan. And I wanted to thank Bob, his brothers, Steve and David, also, for their very generous support of the university. Some of you may know, they've endowed a postdoctoral fellowship in honor of their father, Oscar Kaplan, Dr. Oscar Kaplan, very, very famous psychology. In recognition, I'd just like to ask everyone to give them a big round of applause. I know we have a number of folks from companies and from universities throughout San Diego. One of the great aspects of this town is that people get together and they collaborate. We're really glad to have you all here joining us at San Diego State. As Dean Malloy indicated, I'm so pleased to see that there are students here today. Fostering innovation is really what the modern research university is about. We foster innovation through our discoveries, but also through the education of a new generation of innovators. And together, what those discoveries and innovations allow us to do is to address the broad societal challenges that a great research university should address. Whether it's economic development, public health issues, energy, the environment, all of the challenges that we face, a great research university can address them. What these ideas and innovators also do is they lead to product development and the development of companies that foster economic competitiveness. So on both of those fronts, San Diego State University is moving forward. Today's lecture focuses specifically on innovation in the sciences. And as Dean Malloy indicated, it's really part of a broader focus in the university on entrepreneurship and innovation, creativity. We're really thinking about innovation, creativity, entrepreneurship as the themes of the entire university. So we're asking people to consider whatever you do, think about it as being part of innovation and creativity. So this is just one part of a very, very large initiative. In a moment, Provost Marlin will formally introduce Bob Kaplan. But I just want to take a moment to say thank you for making us so proud at San Diego State. Through alumni achievement, it reflects back on the university. It encourages our students to see that role models are moving forward. Dr. Kaplan's contributions are both scientific, where he has discovered or developed new methodologies and also discovered a number of important findings in treatment approaches, but also leadership in his role in Washington at NIH. he's really leading our national efforts in behavioral and social sciences. So I really can't think of a better person to deliver today's lecture. And now I'd like to formally introduce Provost Marlin. Please join me in welcoming her.
Well, what influences one to become a famous psychologist? Is it genetics, or is it the environment? As you know, this so-called nature-nurture controversy has long been debated by psychologists through means of taking monozygotic twins and separating them at birth, or dizygotic twins and looking at the environment, or adoption studies and so forth. But as was just referenced, Bob Kaplan is a particularly interesting case study because he's got both the genetic predisposition and the environmental situation. Bob's father was Oscar Kaplan, longtime faculty member at San Diego State. I mean, almost half a century. He was such an influential figure. He was really one of the very first developmental psychologists to study the gerontological part of the lifespan development. Psychology, long been focused on early lifespan. And he contributed enormously to the research mission and orientation of the university that we now enjoy. Bob Kaplan also had the environmental situation. He went to the lab school here as an elementary student. He grew up, of course, close to San Diego State University, was an undergraduate student in psychology here. Well, whatever those combinations, and all of you have taken psychology, know it's an interaction of the genetic and environmental factors. Bob has certainly manifested that behavior of becoming a famous psychologist. Graduating from here, he went to UC Riverside, received his master's and his PhD in psychology. He then was a faculty member here at San Diego State University, also a very influential faculty member. He was instrumental in creating the Graduate School of Public Health, and he launched the Center for Behavioral Medicine, which we all know as IBOP today. From San Diego State, he went to UCLA as professor and chair of the Department of Family and Preventative Medicine. UCSD, then UCLA, as distinguished professor of health sciences. And in February 2011, he joined the National Institutes of Health in his current role as Office of the Director, as Associate Director for Behavioral and Social Sciences. He's an extraordinary researcher, author, editor of more than 18 books, 480 articles or chapters. He's included on the ISI listing as one of the most cited authors in the world. Now, to get on that listing, you have to be in the 99.5 percentile. If you're just in the 99 percentile, you don't get on it. You have to be in the 99.5 percentile. That's a very cited author. He has served as the past president of the American Psychological Association Division of Health Psychology. He was the former editor-in-chief of Health Psychology and the Annals of Behavioral Medicine. He's a member of the Institute of Medicine of the National Academies of Sciences, and as of tomorrow night, he'll be one of our Monty recipients. So I am delighted to introduce Dr. Bob Kaplan.
Provost Marlin, Dean Malloy, thank you. And by the way, thanks. I occasionally give talks like this, but I haven't had so many family here before, so thank you. Kathy, Seth, Steve, Dave, Margaret, thank you so much for coming. So I'll probably be a little bit more nervous than doing this in front of family because they haven't heard this before. And perhaps some of you have. I know many of you remember me when I was a colleague, and it is true that like many times I was making slides on the airplane yesterday coming out here, so there probably will be some typos, but so I'm going to talk to you a little bit today about some things we're doing at the NIH. Before I do that, when you're a government employee and you go out and give talks, it is a requirement that you say a little bit about the organization. So for those of you that are not familiar with the NIH, let me tell you a little bit about what we do. The National Institutes of Health is the largest supporter of biomedical and behavioral research in the world. And our mission statement is science in pursuit of fundamental knowledge about the nature and behavior of living systems, and then the application of that knowledge to extend healthy life and reduce the burdens of disease and disability. We have a budget of about $31 billion per year. Our budget is relatively flat-lined now, so that although a lot of other agencies in government are experiencing budget reductions, the Congress has been okay with us, and our budget looks like it will be about the same for the next year. We spend about $5 billion, about 16% of our budget on the intramural program. We run the largest hospital-based program of biomedical research in the world. But we spend the majority of this money, about $25.9 billion, about 85% of our budget, on research in universities like this one. And we support about 325,000 research investigators across the U.S. and in some other countries, again, including a lot of them here at San Diego State University. We spend about half of this money on applied research and about half of the money on basic research. Now, it is also important to say that the NIH, we feel, is a very important part of our economy. We believe, and by the way, all of these estimates come from outside the NIH. None of them come from internal estimates. They're all private estimates from the outside. In 2010, it was estimated that we supported about 488,000 jobs in these 3,000 institutions that we support. And it's been estimated by a couple different sources that the taxpayers get a very good deal on the NIH. We return more money to the economy than is spent by taxpayers. The lowest estimate that has been produced is $68 billion for roughly the $30 billion that the taxpayers put in. So for each dollar the taxpayers put into biomedical research at the NIH, they get about $2 back in the economy. And in some areas, for example, in the genomics area, it's been estimated that it's about 16 to 1. Overall, the NIH is the driver of the biomedical research sector in the economy. That produces about 1 million jobs in the United States, and it generates about $84 billion and about $90 billion in exports. So we feel that we're doing well. We also have supported the work of these three gentlemen who won the Nobel Prize last year, but also overall, we've supported the work of 135 Nobel laureates. Now, the NIH has a fairly simple organizational structure, as you can see here. But in fact, before I went to the NIH, I had no idea how complicated this is. But the NIH is actually a collection of 27 very independent institutes and centers. Each of these institutes and centers has its own director. Each of these directors is a fairly strong personality. They have their own direction. Actually, if you were to take the mouse and click on any of these boxes for any of these institutes, it would just explode into very complicated organizational charts. So overall, we employ pretty close to 50,000 people, although some of them are contractors. It's a little hard to get details of it. And I work in the Office of the Director, which is up here, and we are the Office of Behavioral and Social Sciences Research. The NIH has 4 substantive area offices. There's the Office of Research in Women's Health, the Office of AIDS Research, the Office of Disease Prevention, and then our office, the Office of Behavioral and Social Sciences Research. So each of the directors of those offices is one of the associate directors of the NIH. And we have a broad responsibility for coordinating activity across these 27 institutes and centers. So our job is to get them to work together. And we've now formed into a little subunit, which you can see here. It's the Division of Program Coordination, Planning, and Strategic Initiative, or in government everything has an acronym. It's called DPKIPSI, and that is fantastic. So, in the behavioral and social sciences, we have very broad responsibility, and I think it is worth saying that people in a lot of different disciplines come to us for advice and help. So, for example, all of these academic disciplines see us as their connection to the NIH. In fact, there's some that aren't listed here. So, anthropology, child development, cognitive sciences, communication, and so forth. And then lots of professional schools, so clinical psychology, gerontology, but within the field of medicine, a variety of different areas see our offices, their major connection to the NIH. So ambulatory pediatrics, family medicine, general internal medicine, schools of nursing and schools of social work, schools of public health and public policy are all parts of the communities that we serve. Now, I do want to emphasize that there is a substantial investment in behavioral and social sciences research at the NIH. A lot of people say, actually when I took this job, people said, well, the NIH isn't interested in behavioral and social science research, they don't do much in that area. Actually, that's not necessarily so. about 11% of the NIH investment is in behavioral and social sciences research. So last year was estimated, or 2010 was estimated to be about $3.5 billion. That doesn't sound like a lot, but each billion is 1,000 million. And so it's a fair amount of money. And these are institutes that, so all 27 institutes have a behavioral and social science program, and we coordinate those efforts through a coordinating committee. And these are the institutes that are the largest players, so the NIH and the National Institutes of Drug Abuse and so forth. Now, we also have a basic behavioral science program that we went directly to Congress for, and so there is something now that's called OPNet, which is the Behavioral Science Opportunities Program, where, again, all 27 institutes and centers put money into this program to support basic research in behavioral and social sciences. I coordinate this program with Richard Hodis, who's the director of the National Institutes on Aging. And we spend about $20 million per year in this program, and we're always sort of looking for new ideas. Last year, we had a variety of different requests for proposals, some in stress, sleep, decision-making, and so forth, and we'll be coming out with a series of new ones this year, which unfortunately I'm not allowed to talk about until they're public. Now, this is sort of an obscure connection, but that I think both President Hirschman and Provost Marlin mentioned that my father was a San Diego State professor, and that this is his picture when he became a faculty member at San Diego State in 1946, and he served here as faculty member until his death in 1994. He was a student at the University of California, Berkeley, where he got his PhD in 1937. I think it's 39, I think I'm off on that. But anyway, he joined, jointed. I knew I'd do that. He joined the San Diego State University, it was then called San Diego State College faculty in 1946. One of the things that he was very proud of, and my brothers and I used to hear him talk about this a lot, was he had the first NIH grant in the university and the state university system. And we think it was about 1951. And he tells a story that in the entire system there were no other grants from the Public Health Service, and that they didn't actually know how to receive the grant. So sort of a special process to allow him to grant to be administered here. But I think it is worth saying that San Diego State is doing very well. So again, I grew up in the psychology department, and so I've listed here the top 5 psychology departments in the country in terms of NIH grants, and you'll see here that University of Washington is number 1, University of Pittsburgh is 2, and then San Diego State University is number 3 at about pretty close to $9 million per year. Yorgos is beaming. And UCLA, where I worked before I went to government, is number 5. So San Diego State leads the state of California and is number 3 in the nation, and has been for the last several years. So congratulations, it's doing very well. So when I came to the NIH, my boss, Francis Collins, had me come in to give his talk, and I did this in November, and he wanted me to talk about our new strategic directions, and I'm really very uptight about this, and I went in with a slideshow that included about 80 slides, and I was rushing through all of this and talking, and he looked at me and he said, "It's way too much, way too complicated," and he said, "I want your strategic directions," and he said, 2 is too few, 5 is too many, you can have 3. And so I've been asked to come up with 3 things that we want to develop, and so I'm going to roll through these quickly before I get on to the core of my remarks today. So overall, the strategic directions that we're working on, and call these preliminary because we're not going to roll these out until this summer. We're still getting feedback on these. But we're going to try to develop a variety of initiatives around the next generation of behavioral and social sciences research. And so the first overall direction is the next generation of measurement and data. The second one is delivering services in a reforming healthcare system. And then the third one is the next generation of education and training. So the first one is the one I'm going to spend most of my time on today. This has to do with using electronic health records, mHealth, which is the primary theme I'm going to develop today, system science, and then dealing with data, masses of data that we've never had before, visualizing the data, and then new methods for data analysis. The second theme is dealing with this evolving healthcare system. And one of the areas that we're going to be developing into our component of the NIH is what it's going to be like to have a healthcare system that's evolving. So even under the circumstance that the Affordable Care Act doesn't survive in its current form, the system is reforming, and we know that this is going to happen. And so one of the things that we've been thinking about is what will the world look like, and what does it look like in the past? How are things changing? And some of these ideas come from my colleagues at UCLA, Neil Alfon, and in particular Lester Breslow, who was a mentor to me at UCLA, a wonderful person who died earlier this week at age 97, but had a very profound influence in the field. So what we've been thinking is that the healthcare system has gone through different generations. So the first generation was based on the germ theory of disease, and all of these are based on contemporary theories and understanding about what causes disease. Germ theory of disease was built on the assumption that most of what happens to people is based on infections or germs. And so we built a healthcare system around this a century and a half ago that was largely based on hospital care and attacking acute problems. So that the goal of the system was to reduce deaths. But then we realized that scientific knowledge had kind of moved on. That in fact, there was the realization that about 70% of the people that were taken care of by the healthcare system didn't have acute problems, they had chronic problems. And the Framingham Heart Study came along, some of the epidemiologists I noticed are here. The realization that in fact there were risk factors for these chronic diseases that could be understood. And so Framingham and other epidemiologic studies led us to realize that risk factors were worth modifying and that you can intervene before people were seriously ill. And so the goal of the healthcare system started to shift away from dealing with infections toward dealing with these sorts of chronic problems and preventing them. And the goal was to prolong disability and to promote quality of life. But now we've realized that in fact that still doesn't explain things. Scientific knowledge is moving on again. And the problem is that we're not quite ready for it yet. So what we've come to realize is that in fact there are complex systems that interact with what we do over the course of a lifespan. And so there are multiple determinants of disease. There are social and environmental factors that are much more profound than we thought in the past. And that in fact these influences have their impact throughout the entire life. And so instead of the goal being to prevent disease in the sense of modifying risk factors or curing disease and curing infections, we still have to do all those. But in fact the system has to now deal with this new knowledge that what happens to people actually is the result of these multiple interacting factors that occur over the course of a lifetime. And so you might think of this as, we started out with healthcare systems, sort of like the operating systems on your computer. There's System 1.0, and then we got System 2.0, and now we might have to have System 3.0. And you couldn't run your applications as the systems changed. You had to get new software. So we had System 1.0, and then we had System 2.0. And we think now we might have to build a completely different system that's going to take care of people in different ways. It's going to have to recognize all of this complexity and so forth. So if you think about the lifespan, that the goal of the system goes beyond what we've done in the past. We're going to have to optimize health populations. And so if you think about the older trajectory, we might have this optimal trajectory of health that we're trying to optimize. So we have to bounce this up a little bit. And if we do that, we might be able to change the point in a person's lifespan where they develop symptoms. And if we do that, then we'll save a lot of money. And so the early healthcare system, System 1.0, like operating System 1.0, really dealt with people when they got very sick. System 2.0 started dealing with people when they were developing risk factors. And the argument is that in fact now we need to go to a system that takes into consideration this complexity and deals with people over their entire lifespan. It takes the entire lifespan into consideration. So, the third theme that we're developing is education and training. And I'm going to come back to that at the end of my remarks today. So just leave that for a while, and I'll sort of move on and get back to this. I'd like to introduce the rest of what I'm going to say with an introduction of this man, Egon Brunswick, who was a professor at Berkeley starting in the 30s and died in the mid-50s. He was a mathematician and eventually became an experimental psychologist. And he actually was a very, very interesting figure, which I'll mention in just a minute. But he had interesting students, including Donald Campbell, who's a very famous psychologist, but also Oscar Kaplan, who worked with him over actually, no one really did their PhD with Brunswick. Apparently he was just too mean. But he influenced a lot of different people. And one of the concepts that he introduced was this notion of representative design. was very concerned about experimental psychology, particularly in his time, because he felt that these observations that occurred in laboratories were not representative of what happened outside the laboratories. So that phenomena that occurred under systematic conditions in laboratory didn't generalize well. And he argued for what he referred to as representative design and representative sampling, where you actually manipulated variables outside the laboratory, you did your observations there. And one of the reasons the idea never caught on was it's just too hard, that you'd have to follow people around, didn't have equipment and so forth. So I'm going to talk a little bit about how that concept might be reapplied now that things have changed. But let me just move on to say that we have a lot of different problems where this sort of idea might be very helpful. So one of the common measurement problems that we have in healthcare, well, the two that I'm going to mention are patient-reported outcomes and the gene-environment interaction. Take this question, which is actually very common in health surveys. It says, please indicate your average pain intensity over the past month. Actually, many of you might have had this question when you went to see your doctor. It's becoming very common in clinical practice. Well, it's kind of a dumb question. So what do you have to do to answer this question? Well, first of all, you have to work with your memory, because you have to recall what happened over the last month, which is pretty hard. Then you've got to summarize what happened over the last month, and you've got to average all that information. So it requires that you get information out of this large number of data points, you remember them, and then you put them together. And we know this is influenced by all kinds of processes. So one of the experiments interesting in the literature is if you're nice to people, just before you ask them about their pain, they have experienced a lot of pain over the last month. You give them a cookie, actually, apparently, that reduces their pain. So representative design and representative sampling might be a way to get at these phenomena. So we believe that what we call mHealth, which is this diverse application of wireless and mobile technologies, might be our way to finally get at these issues that Brunswick talked about so many years ago. So wireless technologies, the ones that we are particularly interested in, include sensors. These are miniaturized little devices, monitors, and mobile phones. And we think these have tremendous potential because they're quite portable. I think most of you have one with you. They're scalable. They're becoming very inexpensive. They provide very rich data input. They're quite personal. And they provide data collection in real time. Now, I want to just raise the question, did we see this coming? And everybody's sort of fond of this quote. In Western Union, an internal memo in 1876, they said, this telephone has too many shortcomings to be seriously considered as a means of communication. On the other hand, some people actually had some vision. This little clip from Radio Times in 1924 was the radio doctor, and this is the radio doctor here. It's quite a word. So here's the radio doctor, and the patient is out here in a remote place. There it is. They had Skype, which is interesting. And then this is the patient's data, and it's got the stethoscope being applied and so forth. So it's pretty remarkable for 1924. Well, one of the things that we know that's happening is that these devices are becoming very expensive in our time. And I just like to point out that when I was a student, computers were pretty rare. Here at San Diego State, there was a mainframe, a big mainframe computer. It was very expensive. Not very many people used it. But over the course of time, as computing has become less expensive, and so that there are office desktops and home computers and now portable phones, then the usage has gone way up. But what's interesting is that this represents the total investment in computing. So when computing was expensive, there were very few computers. And overall, even though the machines themselves were very expensive, our investment in that sector was very small. Now that everything's very cheap, actually the investment in the sector is much larger. And this has led to this almost ubiquitous use of these cell phone technologies throughout the world. So in our country, we have 97-some-odd% coverage with the wireless devices. And most countries in the world now are over 90%. There are people from Qualcomm are very fond of saying that in many parts of the world, people are more likely to have a cell phone than they are to have a toothbrush. Think about that. But they also told me, it was interesting, there are about 7 billion cell phones in the world today. And there are about 7 billion people. And the people from Qualcomm told me that they're expecting this market to go to something like 17 billion. And I said, well, that can't be. There are only 7 billion people in the world. How could there be 17 billion phones? This guy looked at me and he said, Dr. Kaplan, he said, do you have a cell phone? I said, well, yeah. And he said, do you have a GPS device in your car? I said, well, yeah. And he said, does your computer hook to the internet? And it turns out I have about 6 of them. And I'm not even that much of a nerd. So this is really happening. So the remainder of the time today, I want to talk about how we think and how we're planning for these technologies to have an impact on measurement, diagnosis, treatment, and on global health. So we'll start with measurement. And I want to just say that when you come to the NIH, particularly in this era, everything is really about gene-environment interaction. So we have the GWAS, and a variety of different genome-wide studies that are going on. The next few slides, I saw something from Kevin Patrick's group, and these were contributed by Kevin, we can feel that these terms like, everything is omics, so there's genomics and proteomics and metabolomics. So we thought, well, maybe there should be exposomics. And so you might think of it this way, that we're exposed to a lot of different things over the course of our lifetime. We're exposed to, in this case, foods, medicines, alcoholic beverages, effects of poverty, frightening experiences, pollution, and so forth. So we know that we can code the genome, and in fact, we can do that for much less money than we could ever before, so that the cost of coding a base pair went from $10,000 to something like 34 cents over the last few years. So there's been remarkable improvement in both doing this, but also in the cost. And so now, it's relatively easy to code the genome. On the other hand, we have this exposome, which is actually not very well coded, not very well measured. But what happens to us is some combination, as Provost Martin mentioned in her opening remarks, it's some combination of nature and nurture. It's a combination of our genetic exposures and our environmental exposures. But unlike the genome, which is now relatively easy to code, the exposome is actually quite difficult. So again, there are epigenetic phenomena that can change your genome, but for the most part, from conception until death, your genome is pretty much constant, and it can be extracted from just about any cell in your body. On the other hand, the exposome changes over the course of time. So, for example, we have exposures in utero, we have exposures in childhood, we have exposures in adolescence, we have exposures in this Viagra commercial, we have exposures in old age. And so there is this remarkable imbalance between our ability to measure what happens to us genetically and to measure the environmental exposures. But the game is changing. So as we mentioned before, there are billions of these cell phones and sensors and all kinds of other technologies. So that the opportunity to get this representative data, representative design, has never been better than it is before. And so I want to talk for a few minutes about how we think this might profoundly affect a variety of different sciences. So, for example, epidemiology, the study of the distribution and determinants of disease. I saw my friend Mike Kricky-Walkin, who's an epidemiologist, has made tremendous progress, measuring things in remarkably crude ways. So, for example, the Framingham Heart Study learned a lot about the relationship between dietary exposures and cardiovascular disease based on 24-hour diet recalls, asking people what they ate yesterday, which for many of us is quite hard. But there are new technologies like this one that we support. This is a little iPhone app where we can take a picture of this meal. It will estimate the protein, carbohydrate, and fat, and calories. And there's an application that will report that and send the information directly into a database. Now, we do know, by the way, that these are not that accurate. So that these applications are not perfect. But engineers are iterating these all the time. So we're continually getting this feedback and fixing them. So over the course of the next couple of years, we expect these to be highly accurate. Kevin Patrick and his group at the CSD have been very interested in bouts of physical activity. There are a variety of different methodologies for doing this. You can get satellite feeds. You can also give people accelerometers. And here in San Diego, you can estimate parks that are promoting physical activity and parks that are not. There are outward-facing sensing cameras like this one. These actually can now be worn as with pendants around the neck with pictures. And so you can get lots of information about environments people are exposed to on a daily basis. There are implantable biosensors. Implantable biosensors are particularly good for measuring amyloids. which change rapidly over the course of time. So, for example, if you want to measure glucose, lactic acid, oxygen, carbon dioxide, and other metabolic abnormalities, you can implant through an injection needle a tiny little sensor under the skin, and this will communicate through Bluetooth technology with your cell phone over the course of 30 days, and it will give continuous feeds of this information. There are a lot of different new approaches to wearable chemical sensors. People can wear little devices that will give you continuous information about what things they've been exposed to. In this case, the National Institute of Environmental Health Sciences has identified hotspots in Arizona where there are high exposures to the various sorts of things in the environment. There's another group from the UCSD group where you can look at carbon monoxide exposures when people are riding bicycles to get continuous feeds of their exposures during commute times. Stress hormone detection. Stress hormone detection has always been hard because, again, the Brunswick's idea about representative design, well, what happens to people in laboratories is very atypical with regard to stress. We really want the stresses that they experience in everyday life. So we've funded a dentist at UCLA who has developed a little sensor that you put under the tongue, and it uses it uses saliva to estimate alpha amylase and cortisol, and it will give continuous feeds through these sorts of technologies. There are all kinds of activity monitors that will allow you to determine how much activity a person is experiencing in their environment. This gentleman has a little sensor attached to his wrist and to his ankle, and they're communicating with this red dot on his hip, which is a cell phone. And that cell phone, again, is taking that information, sending that over the internet to a database. So diagnostics. Diagnostics is another area where we think that there's tremendous opportunity for these technologies. I think to introduce this, I'm going to introduce my boss, Francis Collins. We got Francis enrolled. We're trying to get him interested in these things, since we're interested in them. So the best way to do this is to get him involved. So we got him involved. We got him to volunteer for a clinical trial. And so he went to India about 2 months ago. And so this is Francis in India, and this you'll see.
Clinical trial of this.
Well, it looks like a regular iPhone on the front, but if you look on the back, it has this special case. And these metal strips here are actually electrodes that will detect very subtle signals coming from my heart so that it can record my EKG. Let me show you how that works. So, I need to get up the right app here, and then I put my fingers one on either side, and it takes a little while to settle down. And there you see my EKG beating away at about 92, 93 beats per minute. Nice and regular, I'm happy to say. And I'm part of a clinical trial to test out this apparatus to see how it works. And right now, this EKG is being transmitted in real time to a cardiologist in
Going to Los Angeles. So he's in India, and his EKG is going to this cardiologist in Los Angeles as part of this trial. So there are all kinds of things that are happening in this area. So mobile imaging, there are all kinds of advances in mobile imaging. This actually won an award for the best innovation of the year last year. It was supported by our National Institutes of Biomedical Engineering and Bioinformatics. So that doctors in relatively near future will be able to take this device and get MRI images of people in clinical settings and in ambulatory care settings. This is going to retail for about $8,000 as opposed to a couple $100,000 for something that might be giving comparable applications in a hospital setting. This is the Lucas lensless microscope. This is particularly interesting for people doing international studies. So the microscope is here. This is its size. This is a quarter. It attaches to something like a cell phone. And so you can go out in the field, in this case in Malawi and Mozambique in Brazil. And in this case, they're looking at specimens to determine whether or not people have elevated CD4 and CD8 cells, people with HIV infection. So this side, the yellow side, are wet cell preparation of CD4 and CD8 cells. And these are from the Lucas microscope. And you can see that the CD4 and CD8 counts are almost identical in the two. By the way, this is 10x magnification, and now this is up to 100x magnification. This will sell for not much more than $1,000. This is a portable NMR machine for people that are doing gene sequencing. Again, you can see that this is the palm of a person's hand. That's the magnet right next to the phone. All fits together in this very little unit. This person has a lesion on his lip, and this is a study that's going on in Botswana, Guatemala, and China. This is a little device that now costs about $4,000. All the costs of these go down over the course of time. So this person now applies this, or the provider attaches this to his lip where he's got this lesion. Here's the lesion, which is again getting sent in real time to a dermatologist back in the United States. And so there are all kinds of opportunities to do these studies in very remote locations without a laboratory. Mood screening, all kinds of applications for the iPhone now. This is a very simple one, but again, like that recall question for pain, people's moods change all the time. So when you bring in people in or ask them to do recall, it's really not very accurate, but you can feed people with a mobile phone and get mood information and create databases over the course of time. Now, with regard to treatment, there are all kinds of things that are also going on in this area. I think one of the interesting things about being in behavioral and social sciences at the NIH is that there's increasing recognition that just maybe 3 or 4 risk factors, for example, smoking cigarettes, physical inactivity, and poor diet, may account for about half of all premature deaths in the world. And in fact, the UN General Assembly on non-communicable diseases had a big meeting in September, and they set priorities, and their priorities are to do interventions worldwide to control tobacco, reduce salt, improve diet and physical activity, reduce hazardous alcohol intake, and then to promote pharmaceutical products. Well, there are all kinds of ways that we can do this now. We can intervene in ways that we never thought of before. So again, instead of bringing people to the clinic, we can bring the clinic to people. So with all these new technologies, we can get people like this person using an accelerometer to exercise and get lots of feedback while they're active. There are all kinds of things that are available for epidemiologic and other studies. In this case, cardiac disease management. This is a work done by a cardiologist at the University of Pittsburgh named Schusterman, who is able to attach these ambulatory monitors to people. Oops. And then in real time is able to get continuous records. And he argues that there's a component of the variance in heart rate and heart rhythm that is individual. So in other words, instead of being compared to the normative database, you're compared to yourself over the course of time. And deviations from your own normal are predictive of cardiovascular events. It's an interesting area. This is another one, aging in place. The National Institute of Aging has become very involved in using sensors to help people live more independently. So in this circumstance, the person can be in their home by themselves. There are 2 different ways this is done. One is that the room will detect whether or not people are moving, or you can put sensors on people to detect unusual stillness. I think this is the most bizarre one, but Nokia actually last month got a patent on the electric tattoo. And so this tattoo actually has gels in it, very much like the gels in children's tattoos. And actually it has sensors and receptors in it. And so that a person with this tattoo can be sent signals, and it will vibrate when you're doing the wrong things or so forth. They're actually trying to solve them, I'll show you. So it's a way to send almost like Morse code signals to people, or after on the field or whatever. They say actually that there may be a time when you can sort of not carry yourself when you would just talk to your tattoo. So the final area I want to mention is global health. We think that these devices have tremendous potential for us to understand what's going on in the international community. So one of the things that we've come to recognize is there's been a dramatic change in the wiredness of the world in the last decade. In 2002, there were only about 3 countries that were fully wired. Now, virtually all economies in the world are wired to do this. And in fact, the prevalence and ubiquitousness of these cell phone technologies is everywhere now. And this creates enormous opportunities to collect data in remote parts of the world where we couldn't do it before. And also to intervene. So this woman, for example, is in Uganda. Unfortunately, she's infected with HIV disease. And you can see her here holding this little pill box. And what happens is she takes a very complicated regimen. So she takes different medications at different times of the day, and then she takes a very complicated regimen. So what happens is that at certain times of the day when she's supposed to take her medication, the box beeps, and it opens, and then it dispenses the exact pills she's supposed to take at that time. And then here is her record of pill taking over the last month. And the person that's the PI on this grant, David Bansford, who's at the Boston City Hospital and Massachusetts General Hospital, when he showed us this slide, he had this picture, and he said, here she is, and with her permission, of course, he said, here she is, and he said, and here's her adherence record for today. So she was in Uganda, he was in Bethesda, Maryland, and he had the record of whether or not she was taking the pill that night. So again, it opens up remarkable opportunities. So I also mentioned that there are other cheap technologies that are coming along. This is, how many of you have heard of Google Flu? So many of you have. So this is Google Flu. Google Flu, you can Google it, Google Flu, and then Google Flu allows us to estimate outbreaks of flu. And so the blue lines are the Google Flu estimates of flu, based on people Googling flu and a variety of other words relevant to flu symptoms. And then the yellow is the United States Centers for Disease Control estimates of flu. So it turns out that with all our surveillance activities for flu, it turns out that Google does a very good job. It's also true for Twitter. So a new paper that came out from a fellow at Hopkins looks at tweets where people tweet, I've got a sore throat, I think I'm getting the flu. And it turns out that it correlates remarkably well with CDC's more expensive surveillance system. So, where do we stand with all this? Well, what's the NIH doing in this? That's a lot of people ask us. Well, one of the issues is that we feel there's still a lot of room for study. So, for example, there's still too few data and systematic studies to document that these methods are really doing what they're supposed to do. There's coordination between behavioral scientists, engineers, and physicians. And there are questions about whether or not these applications are going to have unexpected effects. Are they going to send people running to the doctor when they're not really sick? Is it going to run up medical care costs without necessarily producing benefit? So we need to know whether or not these mHealth technologies are going to cause a digital divide, separating the rich from the poor, whether or not they're going to result in improvements in our understanding of the epidemiology of diseases, whether or not they're going to lead to overdiagnosis, whether or not there's going to be an uncontrollable increase in healthcare costs because we have them, and whether or not they're going to lead to better behavior change and improved population health. So one thing that I can say fairly confidently is that we don't think that it's going to cause this digital divide. So, a decade, a little more ago, President Bill Clinton thought that there was going to be this big digital divide, that rich people were going to have these devices and they were going to benefit, and poor people were just not going to. We've looked at a lot of data from this, and it turns out that in our country, it turns out that low-income communities are equally likely to be using these devices as higher-income communities. And it turns out that African-American and Hispanic communities actually are bigger users of these technologies than the white community is. On the other hand, we think we do need more evaluations. So, for example, does e-health work? Does it lead to behavior change? Well, part of the problem is we really don't know. We have 183 million cell phones in the United States. I just looked the day before yesterday, and on the Apple Store, there were 588,492 apps for the iPhone. And I don't know how many there are for the Android, but that's a lot. That's a lot of apps. There's not enough room on your iPhone to get all the apps. But there are just 19 randomized clinical trials evaluating the effectiveness of these applications. And among these 19 clinical trials on smoking cessation, weight control, diabetes control, and adherence to HIV, 7 of them produced positive results, and 12 of them produced null or inconclusive results. And so there are not that many evaluations, and the evaluations that have been done don't necessarily show that they do all the things that they're advocated to do. We know that in certain areas, so a while back, Gary Bennett at Duke University looked at all the weight loss applications. There are 204 weight loss applications. And in weight loss, now there's 13 evidence-based practices. So there's 13 practices in weight loss where there's evidence in the literature that if you do these things, you're likely to lose weight. Turns out of the 204 iPhone applications for weight loss, there was no